Delighted to introduce Dr. Rachel Donnelly, who is an assistant professor at Vanderbilt University in the Department of Sociology. Rachel is an alum of the PRC and UT Sociology. Her research focuses on social determinants of health and health inequalities across the life course with a focus on stress, work, and relationships. And her work has been published in a number of prestigious journals, including the Journal of Marriage and Family, Health and Social Behavior, and Social Science and Medicine. Her talk today is going to focus on population mental health and state context. So please welcome Dr. Donnelly.
Thank you so much, Randy, for that very kind introduction. And thank you all for being here. I'm so very excited to be talking with you. UT obviously has a very special place in my heart. And it's also just one of the best places to be talking about population health, arguably in the country. So I'm really excited to be talking about this project, which is specifically about population mental health. I've been thinking a lot about how individual experiences in the state environment are unfolding at the same time, affecting people's lives, and in this case, affecting their mental health. Make sure I can advance. Before I get started, and so I'm not rushing at the end, I want to acknowledge that this work has been part of a project, an R03 project funded by the NIMH. And I'm going to be talking about a couple of papers and projects, and specifically a paper I'm working on right now involving several collaborators that I've listed here. So Courtney Bone at UPenn, Matteo Farina, who's here today, and then several graduate students at Vanderbilt, Whitney Ferguson, Adam Schoenbachler, and Zhe Zhang. So I'm very grateful for wonderful collaborators who have helped me push this work forward. And so the talk today is going to focus on how state level policies and context shape experiences of stress and mental health. I'm going to be presenting an empirical example that specifically focuses on the COVID-19 pandemic, but I want to state from the outset that I do think that this framework applies to mental health more broadly, sort of pre-pandemic, post-pandemic. I think the idea of individual level experiences and state policies are something that we need to be thinking about when we think about population mental health and perhaps other outcomes, which I'll discuss at the end of the talk. So my plan for today, I want to situate this talk within the concept of what we know about mental health right now. And then I want to discuss some theoretical perspectives that I'm thinking about that guide this work. I'll present an empirical example testing this theoretical framework. And then I'll discuss some implications of this work, some future directions, and I'll wrap it up there. And I'll look forward to your questions in Q&A. I'm also happy to answer, clarifying questions or any questions that come up throughout the talk. So starting with mental health, if we think about sort of the year prior to the start of the pandemic, April to June 2019, what we know is that if we look at something like the prevalence of recent experiences of depression and anxiety, so in this case, within the past 2 weeks, we know that about 7% of the population said that would sort of meet a clinical threshold for depression, and 8% would meet a threshold for anxiety. This is based on surveys, so it's not actually a clinical diagnosis, but these are validated measures, and I'll talk about the measures a little bit. It's a similar measure that I'll use today in my study. So that's sort of what we know was going on prior to the pandemic. What you guys are probably aware of and may not be surprised by is that at the start of the pandemic, so same period, but in 2020, these rates skyrocketed. So all of a sudden, the prevalence of depression in the population is more like 24%, and anxiety is more like 35%. So, nearly tripled for each of those, very high rates. And if we look throughout the pandemic, so in this case from April 2020 to about November 2022, we see that there's some fluctuation in these rates. Rates of depression and anxiety do come down a little bit here. Sort of this is our early 2021 period. Vaccines are becoming available. Maybe there's a little bit more optimism. So we do see some fluctuations along the way, but really still high rates of depression and anxiety in the population. Because remember, pre-pandemic, we're starting down here, right, at our 7 and 8% of the population being depressed and anxious, right? So very high levels of depression and anxiety throughout the pandemic. a lot of the explanations for these high rates of depression and anxiety focus on individual level experiences, which make a lot of sense, right? People were experiencing social isolation. People were experiencing a lot of economic hardship, financial insecurity. There was just this existential threat. You had feelings and you're concerned about your own health, the health of your loved ones. So all of these are very important explanations for mental health. And we see this when we think about mental health pre-pandemic too, a lot of focus on the individual. But what I want to think about is these individual experiences are of course important, but we need to put the individual in the context of the state or in their broader context. And in this case, I'm focusing specifically on the state. So I'm asking questions like, how do the macro level factors like state policies or state context shape mental health? And in this case, I'm using COVID-19 as a case primarily for data reasons, but also because it's practically important and relevant for a number of reasons that I've already alluded to, like that high prevalence of depression and anxiety, but also the high prevalence of stressful exposures in the population. We have a lot of stress going on, which is going to be central to how I'm thinking about, mental health in state populations. So we have a lot of stress. We have a lot of adverse mental health outcomes like depression and anxiety. At the same time, we have a lot of action in terms of policy that's happening at the state level. So this certainly isn't an exhaustive list, but we can all remember that there was state to state variation in things like stay-at-home orders, the closures and reopening of restaurants, face mask mandates, workplace protections, eviction moratoria, utility shutoffs, paid sick leave, and so on. So we just have a lot of action at the state level, which makes this a really interesting time to be thinking about how state policies could be affecting individuals. This is all on top of existing variation in state policies that have documented effects on health and mortality. So we have the existing political landscape, which varies drastically across states in ways that's consequential for physical health and life expectancy. And then on top of that, we have all these pandemics specific policies happening. So overall, just a really interesting political landscape. So I want to turn to some of the theoretical perspectives that I'm thinking about now that I've sort of hopefully set the stage a little bit in terms of what mental health is looking like at this time. And this work is guided by two main theoretical perspectives, the stress process model, as well as a socioecological model of health. The very brief summary of the stress process model, for those who may not be as familiar with it, is that stress is a key determinant of mental health. This can be things like substantial life events, as well as just chronic strains, chronic stressors. So a whole host of stressful experiences are determinants of mental health for a variety of reasons. Individuals can often harness their coping resources to mitigate these consequences of stress. And importantly, those coping resources are often at the individual level, right? We're thinking about things like social support, mastery, sense of control, those sorts of things. Another key point of the stress process model is that we have unequal exposure to stress in the population, which facilitates, contributes to inequities in mental health. So stress is most likely to impinge upon folks who have the least privilege and power in society, and this contributes to inequities that we see in mental health. So there's our stress process model in a nutshell, very focused on the individual level, very important, and folks have used this framework in mental health research for decades now. At the same time, we have a socioecological model of health, which tells us that if we're thinking about, population health, for example, we need to be thinking about individual level factors, meso level factors, and macro level factors, because folks are embedded in their social environments. So we can think about individual level characteristics as well as individual level behaviors. At the meso level, we could think about family interactions, workplace environments, neighborhoods. Those would all be key meso level factors. And at the macro level, we would have things like institutions and policies, which is what I've been thinking about and focusing on, specifically those state level policies and contexts. So, and states are particularly important. There are other macro level factors that we could be thinking about, but states are particularly important because they have an increasing amount of power and authority in terms of their policymaking powers. The devolution and preemption movements have been primarily responsible for this, giving states power from the top down as well as the bottom up. So we have a lot of policymaking authority at the state level. And because of this increasing authority, we have increasing polarization in policies across states, making this really important for thinking about unequal experiences of health, right? So for example, your policy environment in Mississippi is drastically different from your policy environment in New York, and consequently the life expectancy in those two states is drastically different. And there's really strong evidence now, based on the last 5 to 10 years, that these states are determinants of physical health and mortality risk. We really don't know much about what's going on in terms of states and mental health. So what I do is I blend these two theoretical frameworks, the stress process model and that socio-ecological model of health, to think about how state policies could impact mental health, but also how state policies could impact those experiences of stress that have adverse consequences for mental health. So essentially, can states and state policies impact that individual level stress process? And previous work has situated the stress process model within the context of neighborhoods, more like that meso level experience, thinking about how neighborhoods can be a source of stress in particular. But really, the stress process model hasn't gone to that macro level, which is what I'm aiming to do. So for folks who are maybe a little bit more visually inclined like I am, if we think about some of these individual level processes, we can have a number of stressors. These are sort of relevant to the pandemic and beyond, of course. They're going to have a lot of impacts on mental health. Of course, they are not equally experienced by things like race, education, gender, and even age. But then we have all of this is occurring within the context of state policies and context. And those could be sort of economic related policies, things like even just like the minimum wage in a state, for example. These could be safety net policies, whether that's sort of Medicaid eligibility or something like unemployment insurance, and even policies related to more directly to health and health behaviors. But these policies could directly affect mental health. It could moderate that association between individual level stressors and mental health. And something that I haven't really looked at, but would be an interesting area for future research, is that they could also just be contributing to the likelihood of experiencing some of these stressors. If we think about having some of these social safety nets in place, maybe reduce experiences of financial hardship, for example. So this is broadly the conceptual framework that I've been working with. And we have some initial evidence that there's something going on with this framework. So Matteo and I published this paper in 2021, where we looked at household income loss as the stressor and the effects on mental health. And we found that state policies moderated this experience. So for example, living in states that had expanded Medicaid eligibility under the ACA, had more generous unemployment insurance in terms of the maximum amount that you could qualify for or the duration that you could qualify for. And states that had, this was pandemic specific, had freeze on utility shutoffs. If you lived in states with any of these policies, the effects of income loss was still detrimental to mental health, of course, but it wasn't as bad as if you lived in a state without these policies. So these policies were providing some protective effects against mental health for folks who were experiencing income loss. And this was focused on sort of like the first couple of months of the pandemic. It's really small there, but April to July 2020. So despite this, this initial evidence that was really exciting to find, there's certainly a number of questions that remain, and some things that I was thinking about were, okay, does this framework stand up against other stressful experiences than just household income loss? Does it apply to sort of vulnerable groups of people, which is more like what I'm going to be talking about in a minute? Does this process even unfold in similar ways across race, gender, SES, age? And do we see similar results when we're looking at changes in state policies? So in the paper that I just mentioned, Matteo and I were sort of looking at states that sort of had these policies at that time, but not, okay, what happens when a state sort of implements a policy? Do we see a change in mental health because of that? So based on this framework and some of these questions, I'm going to talk about an empirical example that tested some of these questions and gave us additional support for this argument. And this paper focuses specifically on paid sick leave as the policy that we're interested in and how that affected mental health. We focus specifically also on the experience of financial hardship in the household. So that's sort of our stressful experience vulnerable group is financial hardship. So we wanted to know, okay, if you're experiencing financial hardship, does living in a state with paid sick leave sort of moderate or mitigate some of those adverse consequences? And this is a paper with 2 graduate students, Whitney and Jia, as well as Courtney Bowen. Okay, so starting, what do we know about financial hardship and mental health? Perhaps not surprisingly, there are really robust linkages. So again, in this case, we're thinking about financial hardship as that stressful experience or as that sort of vulnerable state. There's robust linkages between financial hardship and mental health. There's a number of mechanisms that we could think about that might explain this, such as financial hardship creating sort of psychological distress, reducing mastery or self-esteem, leading to sleep disruptions, leading to specific forms of insecurity like food insecurity or home insecurity. So there's a number of mechanisms that suggest this robust linkage is pretty accurate. And we know that financial hardship was pervasive during the sort of first 2 or so years of the pandemic. So about 1 in 3 households reported financial hardship between 2020 and 2022. And in terms of sort of what did this look like pre-pandemic, we don't have sort of like the exact same question, but we know that about 6% of adults found it difficult to get by in 2019. So we could think about how that probably fairly accurately maps onto something like financial hardship. We also know that there's inequities in exposure to financial hardship by SES, race, gender, age, both before and during the pandemic. So financial hardship is not equally experienced, and therefore is likely contributing to any inequities we see in mental health. Okay, what do we know about paid sick leave? Previous research on paid sick leave policies tends to focus on health and health behaviors. The idea being that, okay, if you have paid sick leave in your state, then you're not going to come to work, or you're less likely to come to work if you're feeling sick because you have that protection. So there is evidence that access to paid sick leave as a policy decreased COVID-19 cases. It reduced the share of workers who worked while sick, and it lowered transmission rates. So there's some emerging strong evidence that paid sick leave is important for these health and health behaviors. There's also evidence that sort of individual access to paid sick leave through an employer. So if I have paid sick leave through the university, even if the state doesn't provide paid sick leave, that improves economic security and mental health. So this research is less focused on paid sick leave as a policy, as much as just individual level access to sick leave. But sort of that would give us some good indication that maybe there's some mental health implications. Importantly, I want to note that there's stark inequities in access to paid sick leave, especially when we're thinking about sort of individual access through an employer rather than a blanket policy that's going to affect people in a more equitable way. So with this in mind, what we wanted to know is, can state paid sick leave policies shape mental health, especially among financially vulnerable households? So it could be that paid sick leave minimizes income loss when people are sick or when they have to provide care to people in their household who are sick. It could be that it reduces the threat of job loss if you're having to miss work because of these caregiving needs. And it could be that just sort of reduces stress broadly around all these sort of conflicts that we often see with work and family. So specifically in this paper, our research questions are, how do paid sick leave policies moderate this association between financial hardship and mental health? And does this process, this like moderation process, unfold similarly across race, gender, educational attainment? The data that we're using to answer these questions come from individual level survey data from the Household Pulse Survey, which is a nationally representative survey administered by the Census Bureau along with other federal agencies. It's a really cool survey for folks who don't know about it. And the idea was to ask about things that were really relevant during the pandemic, like economic experiences, sort of household, caregiving, school disruptions, all sorts of these like social and economic things. But importantly, they also asked about mental health, which is kind of rare for a census survey. So that was really exciting. They also ask about what state you live in and make it publicly available without needing restricted access to data or anything. It also occurs really frequently. So they wanted to get sort of this real-time information about what was going on in people's lives. So it's administered about every 2 weeks. The first survey was in April 2020. But this study is going to start in the 13th week, so August 2020. They didn't ask about financial hardship prior to August 2020, which was wild to me, but that is what we're dealing with. So we use data from August 2020 to November 2022 in this survey. The state level paid sick leave in terms of which states had paid sick leave and when they implemented it comes from a couple of sources, which I've listed here, that have documented this information. If it was ever sort of unclear if there were any conflicts between sources, we just went directly to state websites and looked for the documentation on their website. But what we have in our sample is almost 2 million adults between ages 18 and 65. We focused on these age ranges, thinking that maybe paid sick leave laws, which are related to working, would be probably most relevant for this group, but I'm happy to talk about that further. And just to give a little bit more information about the Census Bureau, or to give you an idea of what it looks like, there are a lot of pros to it, which I've mentioned. One con is that it has a fairly low response rate. They've done a lot of work about how sampling weights can help with this. But because I forgot to mention it's a web-based survey, you can imagine how that might sort of affect response rates. For example, I was so excited in a very nerdy way when I got this text message to participate in the household pulse survey. But you can also see that I ignored it for 2 days because I thought it looked really spammy. If you're like me, you've had to take like a million courses about like phishing. I never click links or anything, but if you go to the website and they do say that it will come from this number. So I confirmed that it was okay. And I did participate. I think I can disclose that. But just to give you an idea, so this is, they've tried to sort of reach people in multiple ways, including through text message, which may pose its own challenges from a data collection perspective, which is really interesting. Okay, that's the household pulse survey. The dependent variables for this study are depression and anxiety. They asked 2 questions about how often in the past 7 days you've been bothered by having little interest or pleasure in doing things, feeling down, depressed, and hopeless. For anxiety, they asked about how often you felt nervous, anxious, or on edge, or not able to stop or control worrying. You can see the response options ranged from not at all to nearly every day. For each of these 2 measures, depression and anxiety, the 2 items are summed. So they would range from 0 to 6. And then there's validated cut points. So anyone who scored more than 3 or above on either of those is classified as having sort of like probable depression or probable anxiety. You can also examine them on that continuous scale and results are the same. Financial hardship asks folks how often in the past 7 days they had difficulty paying for usual household expenses. This could be things like food, rent, car loans, or car payments, loans, medical expenses. So they gave like a few examples to folks. And then we classified folks as experiencing financial hardship if they found it somewhat or very difficult to pay for usual household expenses, or not at all or a little bit difficult. Paid sick leave was a time-varying measure, so it was coded 1 when the state had the active paid sick leave policy in place. And we control for a number of covariates that I've listed here, a lot of socio-demographic characteristics and characteristics of the household, like there's children in the household and how big that household is. And again, I'm happy to talk more about these. Our approach is that we use linear probability models with state and weak fixed effects. And the idea here is that that weak fixed effect can absorb trends at a national level. So if we have sort of major federal policy that's implemented, it would try to absorb some of the bias there. State fixed effects are going to absorb some of those time invariant confounders at the state level. Because the study is sort of like every 2 weeks, we can think about those, the composition of states isn't likely to change within like a 2-week period. So that would be an example of a time invariant confounder in this study. We clustered standard errors by state and applied sampling weights. And the results that I'm going to show you sort of follow the pattern where we regressed the outcome, either depression or anxiety, on financial hardship and the paid sick leave policy sort of separately, including covariates to see what's going on there with the main effects. And then to answer our main research question, we added the interaction of financial hardship with paid sick leave, because this tells us, okay, does living in a state with paid sick leave sort of weaken, moderate that association? So just first to give you some descriptive statistics, this is what sort of the prevalence of financial hardship is. I sort of alluded to this already, but just over 1 in 3 households experienced financial hardship during this observation period. Depression and anxiety, of course, remain high, 26%, 33%. In terms of paid sick leave policies, 12 states had policies prior to the start of the pandemic, and then 4 states plus DC implemented a policy during the pandemic. So not a ton of states have this, and there's not a whole lot of like adding and dropping during this time, which is something to think about when we're thinking about these linear probability models. Also important background information or interesting background information is we did have the Families First Act in March 2020 that mandated national sick leave. The caveat is that it excluded workers at large companies, which is wild, right? It also expired at the end of 2020. So we really aren't, and again, our study started in August 2020. So I don't think that this is that relevant for our study. And so we don't really handle that, but happy to talk about that as well. There's also some studies that folks didn't even know that they had access to paid sick leave under this policy. And so I know this is tiny. I don't expect you to be able to read every single state, but just to give you an idea of what you're looking at, time is on the x-axis. So in terms of the weeks of our survey, that August 2020 to the end of 2022. If it's a 0 across the board for states that never had a paid sick leave policy, it's a 1 across the board for states that always had a paid sick leave policy. And then we see the action of a few states that added paid sick leave during the study period. So the main thing is sort of, you see sort of some states always had it, some never had it, and then some adopted a paid sick leave policy during the study. So a little bit of action here. Okay, turning to the main research question, the first research question. So how do these paid sick leave policies moderate this association between financial hardship and depression and anxiety? If we start with these main effects, we see that in line with prior research, and perhaps not surprisingly, unfortunately, experiencing financial hardship is associated with a 26-point increase in depression and 31% percentage points increase in anxiety. So very robust associations. There's a little bit of evidence for this direct association where living in a state with paid sick leave is associated with slightly lower risk of depression and anxiety. But it's a fairly small effect. When we add the interaction term, what we see is that living in the state with paid sick leave reduces that effect of financial hardship by about 3 percentage points. So this main effect now is the effects of financial hardship for folks without access or not living in a state with paid sick leave. So pretty strong association here. If we take folks who lived in a state with that paid sick leave, it reduces that association by 3 percentage points. And interestingly now, this paid sick leave represents folks who are not experiencing financial hardship. They're not really affected by this policy in terms of their mental health. I know average marginal effects are going to be easier to see. So just to give you an example with an illustration of what this looks like, these bars are essentially representing the difference in depression or anxiety between folks with financial hardship and without financial hardship. So it's essentially like the magnitude of the disparity. So what you see is these dark blue bars, that's the disparity for people living in states without access to paid sick leave through a state policy. And this is the disparity for folks in states with paid sick leave. So again, financial hardship is still associated with depression and anxiety strongly, but we at least see a little bit of reduction there. That disparity just decreases just a little bit by 3 percentage points for folks who have access to this policy. And does this process unfold similarly across race, ethnicity, gender, educational attainment? First, I just want to emphasize, I made this point earlier, but just to show you what it looks like, there are stark inequities in exposure to financial hardship. So for example, if we look over here on this left panel, what you see is that the red and the gray bars are non-Hispanic white and non-Hispanic Asian folks. Folks up here, the blue, kind of hard for me to see the colors. Those are non-Hispanic, Black, Hispanic, and other racial ethnics. So we see they're much more likely to be experiencing financial hardship than non-Hispanic white and non-Hispanic Asians throughout this study period. We can see sort of these inequities play out in depression and anxiety too. If we look at gender, we see that women, the gray bar, are more likely to be experiencing financial hardship throughout this pandemic period than men. The household pulse survey also asked about gender identity, which is really cool, although it didn't start until like the 34th week. But we see transgender and people who say like none of these genders apply to them are experiencing much, much higher rates of financial hardship. So really stark inequities in exposure here. And again, this maps onto depression and anxiety as well. Finally, if we're looking at education, we again see the strong gradient that we would expect. Folks without a high school degree, folks with a high school or a 2-year college degree, and then our highly educated folks down here, much less likely to be experiencing financial hardship, and same with depression and anxiety. So really, really stark inequities in who's experiencing financial hardship. In terms of how does this process unfold, what we find is that there's not support for what we would call like differential vulnerability. So paid sick leave is moderating this association for just about everyone. It doesn't matter race, it doesn't matter gender, and with one exception, it doesn't matter educational attainment. So we can think about this as paid sick leave is sort of uniformly important for mental health for folks who are experiencing financial hardship. The one exception that is actually interesting is that we didn't find evidence of moderation among adults with the highest level of education, those with a graduate degree, which actually kind of aligns with findings about sort of state policies and physical health, which is that adults with less education are often more vulnerable. It makes sense, right? Like higher FCS folks can use their resources. It doesn't really matter as much what these policies are doing. So that was the one exception to sort of this differential process that we found. And it's not part of the original paper, but of course, when I was coming here, I was thinking a little bit more about age, and we do see this differential exposure going on. It's not quite as pronounced if we look over here, but the youngest folks in the sample have the higher rates of financial hardship and higher rates of depression. So we see that differential exposure playing out by age too, which maps onto prior research. And again, we don't see differential vulnerability. So this process is unfolding similarly across age groups. So just to summarize, I know there's a lot of figures. To summarize what's going on here, we're seeing that not surprisingly, there's higher rates of depression and anxiety for those who are experiencing financial hardship. We also find that paid sick leave moderates this association between financial hardship and mental health. And perhaps it's because some of the factors I've listed here. And then there's also strong support for differential exposure, but not for differential vulnerability, meaning that financial hardship is not experienced equally in the population, but these effects of paid sick leave seem to be unfolding similarly. Okay, so what do we do with this information? First, I just want to note a few limitations that I'm thinking about with this study. One is that we really don't know anything about the chronicity of hardship, which is really important because chronic financial hardship is going to be a lot more consequential for mental health than sort of just like episodic or short-term financial hardship. So they just don't ask about this in the pulse survey. We don't have this information. It could be that paid sick leave would be especially important for people experiencing chronic financial hardship. So there's important implications there. As I mentioned, this is also sort of repeated cross-sectional data. So we can't sort of control for baseline mental health, and we can't look at within-person changes in mental health based on changes in financial hardship and paid sick leave. So that would be a really cool area for future research if folks are, collecting longitudinal data like this. And I mentioned it's also sort of an internet-based survey, and there's important limitations there, like the fact that it would exclude people without internet or without smartphones, who I think we can reasonably imagine are probably going to be more vulnerable and have higher rates of financial hardship. I think what this study is doing, hopefully, is adding to the growing evidence that state policies can weaken the adverse mental health consequences of stress. So I showed you that paper that Mateo and I did, looking at household income loss and a number of state policies. There's also some additional work coming out, sort of mapping onto this framework. So Courtney had a recent paper in JHSB looking at eviction moratorium and financial hardship. I had a paper that is forthcoming with a grad student at Vanderbilt looking at essential workers, the idea being that they were experiencing a lot of stress and also a vulnerable class of workers who may benefit from certain policies. And then Mateo and I also had a recent paper last year looking at even anticipated stress. So folks who even anticipated that they were going to experience financial like food insecurity or have trouble paying for rent benefited from living in a state with more robust social safety nets. So overall, I think what this research is hopefully showing is that the stress process model in particular should consider state as an important context. So I noted at the beginning that the stress process model is considered neighborhoods, but not really anything more macro than that. So I'm trying to situate this process within the context of the state environment. And I think it's also really important to come back to this point about differential exposure and differential vulnerability. So we know that exposure is central to the production of inequities at the population level. So it's really important to contextualize all of this within the context of those stark inequities in exposure to financial hardship. With vulnerability, we're not finding evidence that these processes are unfolding differently across folks. So it leads me to ask, okay, are there just sort of like different mechanisms that are operating for folks in terms of how paid sick leave is important that sort of just like net out? Or is it just that paid sick leave is universally important? I could see that being completely valid. So, that would be sort of important to be teasing out in the future. I noted that these effect sizes are fairly modest, right? It was like a 3 percentage point reduction. We're not all of a sudden getting rid of the mental health consequences of financial hardship. But importantly, this study, the outcome, we were looking at sort of what should map onto clinical levels of depression and anxiety. So any reduction in a clinical level of depression and anxiety is arguably fairly important. We're also talking about a large number of people affected by policies. So again, if we're thinking about, okay, the number of people in a state and a reduction in clinical levels of depression and anxiety, we're talking about a large number of people being affected by these policies. And importantly, this is just one piece of the social safety net that people are living in. So, maybe if paid sick leave is mitigating this association by 3 percentage points, we should also be thinking about, okay, what are these other policies contributing to that? I think it's also important to be thinking about paid sick leave as an endeavor for health equity. Again, because of this differential exposure to financial hardship, differential exposure to even living in a state with paid sick leave, it's important to think about how these policies could be inherently sort of improving or reducing inequities in mental health. It's also important to think about these as sort of like possibly unintended benefits. I'm not sure to what extent policymakers think about paid sick leave in terms of its mental health benefits. I think often the conversation is about the health behaviors and health, reduction of transmission of disease. So these are sort of maybe perhaps unintended benefits that we should consider in like a cost benefit analysis. That being said, paid sick leave at the state level is inherently unequal, right? It's going to inherently affect people in different ways based on the state of residence, which points to the need for a national paid sick leave policy, I think. So just want to touch on some future directions for this work. I think it would sort of be important to make sure this is mapping out and playing out in a post-pandemic context, and whether that's with paid sick leave or with a host of other policies that we've considered in our work. And an empirical examination of what mechanisms, like why are these specific policies actually affecting the mental health of folks, especially folks experiencing stress. I'm also thinking more about the evidence of state policies as determinants of mental health, regardless of that stress experience. So there was that tiny effect where paid sick leave was improving mental health sort of overall. So, I think there's work to be done sort of in terms of how policies could be directly affecting mental health versus to what extent they're just, not just, but to what extent they're working with sort of experiences of stress and vulnerability. I'm also thinking a lot about to what extent this framework, thinking about the individual experiences and state policy, maps on to other outcomes. So mental health is really interesting because we could think about it as likely being more reactive to changes in policies and changes in people's lives. But what about other outcomes that have a longer latency period, which would point to the need to think about life course exposures to state policies and how that could be affecting physical health outcomes and mortality risk, for example. So I think it'll be important to test to what extent this framework plays out and is mental health specific versus specific to other sort of longer latency period diseases. Okay, so I'm just going to wrap up by saying, hopefully I've provided some of, maybe I've convinced you just a little bit that states should be considered as determinants of mental health and contextual factors for the stress process model. I think this also points to the fact that haphazard adoption of policies from state to state are going to create and exacerbate inequities. This applies to existing and pandemic-specific policies. And when I say inequities, we could be thinking about sort of geographically across state to state inequities, but also sort of population inequities based on sort of who has access to these policies and who doesn't. And it's important to think about population mental health on its own. It's important in a dimension of well-being and important in its own right. But it is also important because there's a lot of robust linkages between mental health, physical health, mortality risk. So if we're contributing to geographic inequities in mental health, then we could be sort of fueling and contributing to some of these geographic inequities in physical health and life expectancy. So I will end there, but I very much look forward to any of your questions or comments.
Thank you so much, Rachel. I just want to remind everyone that the first two questions go to our graduates.
Hi, thank you, presentation for giving me. I have one macro question, I guess. One is, if you looked at merits and status, or qualification was one of those factors that show the difference or no difference. And second, I was wondering if paid, like the states that have paid sick leave policies are also states that companies are more likely to provide those individual accesses. Is there a gap between state policies and individual access between the non-states that doesn't have the policies? Did it make sense?
Yeah, that's a really great question. So in terms of marital status, we haven't looked at that actually as sort of does this process unfold differently, which could be really interesting. I mean, we control for it, but if you have a spouse, that means, okay, there might be two people who are working who would benefit from paid sick leave policies. So, that could be particularly important. It could also be that, if it's just sort of the individual, maybe then they're just focused on sort of their own access to leave. So I think there's really interesting implications there. I'll have to look into that. I just haven't done it yet. But your point about organization access and the state environment, I also don't know. I don't know of data that I can think of at the top of my head where I would know about the percentage of, actually the household pulse survey asks about if you haven't worked within the past week and whether you were compensated for it. So that sort of gets at that individual level access to paid leave essentially. So we could compare and see, okay, the rates of people by state and where, if they're falling in states that have access to leave versus if they're likely to be experiencing it from an organization. So haven't looked at that in that way, but that would be really interesting. Yeah, thank you for those good ideas.
I have a question about putting the state level effect as a policy. How do you sort out the effect of the paid sick leave policy and also many other things that we need to if you use a fixed effect model? Doesn't that mean control for every time-varying thing related to the state, which is a particular state? So I wonder how you can sort out the effect of the policy.
Yeah, this is a really good question. So I've gotten this sort of question from reviewers. So you're very right to be pointing that out. I think we need to think more about how to do that. We could control for other policies and then see sort of what the net effect of paid sick leave is. We've looked at other policies in our other work, so I have that data available. I can just control for it. There's also sort of like state, like liberalism scores that are out there. Jennifer Montez has done this work. So we could even just sort of account for that to see what's going on. But yeah, you're absolutely right. Like we could do more to isolate just the effect of paid sick leave in particular. Because some folks who have done sort of work on state policy will do more of that diff and diff approach. So see like what happens after the policy goes into effect, which isn't exactly what we're doing here. Yeah.
So I have do you have any theoretical hypotheses linking the two together? Maybe to the false negative?
And linking what too, sorry.
The why policy could be the real cost. You're using the same data, we can control like the methodology.
Yeah, you know, I mean, I think the idea that we're mainly, the theoretical mechanisms that we're focusing on are mainly about the economic consequences. So just having like financially vulnerable houses are going to benefit from not having income loss when they have to miss work because they're sick. So the main reason why we think that this would be important for financially vulnerable households would be like that they're not having that reduction in very needed economic resources, and also maybe not facing like a threat of job loss if we're talking about longer periods of work. So yeah, so the mechanisms we're thinking about are mainly about household economic resources. So maybe we can even more directly test that models.
So policies run impacts.
Yeah.
They're not haphazard in how they spread across states,
Mm-hmm.
you know, honestly. And I wondered how you thought about this, because if you take a look at the income policies here, have you linked them up with the other policies? Because you could go to them, you could look at all the policies that we've used to do the study of state liberalism scores, and you could actually tie in the scores with those. And,
Yeah.
and the other thing I think, right now, we're still thinking about the one policy. It's a kind of classic economic approach to thinking about how things are occurring. But multiple policies are usually coming into play. And so in some ways, it might be interesting to see the ways in which this kind of the paid works with respect to the other policies that are out there, you know, and how they track over time, for example.
Right.
So, you know, you could probably get a lot of purchase on that. Because I would bet it would cluster in those states with the other policies that provide the strong safety nets, right? So.
Right. No, you're absolutely right. I mean, you know, part of the idea of this, you know, hyperpolarization of policies is that they all start grouping together, right?
And they happen like a couple at a time. If you look at, like Jennifer had a recent paper that I think you know, Milbank. So it was like, well, how policies that are bundled together, right? That are coming through legislatively within a year. So it's not like it's a political agenda in which things are enacted.
Right.
So-
Right. Yeah, no, I mean, and I think a lot about this because I think there's pros and cons of both. So I think, you know, the policy score type approach would tell us a lot about this state variation in mental health, to what extent are that policy network mattering, which is really important. I think the individual, if I was going to push back and say focusing on individual policy, it gives us more purchase in terms of policy implications. You know, what does a state legislature then think about? You know, it's like this state policy might actually have an effect, whereas a cluster of states, it doesn't have that like direct policy line. But yeah, no, I think about it a lot though, because it is, I think both points are important. So maybe there's ways to even incorporate both.
I think the bundling has challenged us to look at causality of single policies.
Yeah.
And I think that has been a real, you can't use the national experiment of timing policies anymore because of how they're bundled together. So it is a challenge to think about the kind of history of which policies of different types are enacted.
Yeah, that's a good point. And the paid sick leave ones are generally very recent. You know, I know I said some already had some prior to the pandemic, but we're talking 1 or 2 years.
Yeah.
So they're sort of all happening at the same time.
Yeah, so I wanted to take a slightly different tack, which was the resources available. And I think it's sort of a little bit on my first question, which is, so if you look right now at what's happening at state level in terms of like availability of doctors, some of the states are no longer keeping track of that. My hunch is that AMA, the American Medical Association, tell you that based on zip codes and things, if you can convince them to give it. So, I mean, I'm kind of saying the great equalizer is everybody's going to suffer. If you can't go to the doctor, if all of the mental health providers are gone, then you've got a whole other level reaching to it. And the reason I think it speaks to that earlier question is, are there employers in the state
who are the employers beyond the liberalism? And I think some of that is stuff that's outside the reach of census, that it would be really interesting to see some data merging in that regard, because it's kind of like, how low can we bring everyone? It's in the state as opposed to how.
Yeah.
I mean, I love your approach, which will raise people up, but on the other hand, if the resources don't exist, then you've got another issue. Anyways, I just wanted to raise that simple pressing point for you.
No, that's a great point in thinking. I think the idea about thinking more about like what's available to employers or not is really important too. And it might explain some of the small effect sizes too, because even if you live in a state like Tennessee, like I do, and have access to paid leave through my university, which I do, then, these things aren't going to quite be as relevant.
Yeah. It's also partly that, I gotta be honest, I'm noticing that in Austin, that there's less access, that people are leaving and retiring. So being really, resource rich and whatever personally, if you can't access it, and you see that a lot in the paper now too, people who will say, well, I could have gone some other state, but I was too sick and I couldn't get the access to care. So anyways, it's just a really depressing thought.
I love it. That's what I do. Yeah, for sure.
So there were two things. The one thing that came up that kind of, I think, maps onto what Mark was saying and what Karen was saying, is the idea that there are these multiple policy clusters that could have an impact. Because as you were talking about paid sick leave, I was thinking about Uber drivers and other gig economy employees that don't have access to paid sick leave, but eviction moratorium, for example, might be something that would be more impactful for them. Or, so like, thinking about these different populations within the states even, right, that you're gonna see this kind of variation of which policies are going to have. So that was one thing that it occurred to me, and I would just, I don't know if you had any kind of thoughts on that, but like.
No, it's a really great point. And I mean, I think the work one in particular is important to think about. Like I've thought about even just doing sort of like using California, who's sort of gone back and forth about whether gig workers should be considered contractors, and seeing sort of how that maps onto some. I've thought about it. I haven't pursued that, but this would be a good way to even like think about that state policy environment, other than just sort of the protection that they'd be getting.
And the other thing that came to me was when you're talking about this as kind of a mental health issue, I was thinking about this also in terms of how like policymakers and how much they actually care. Right. So to the extent that they even care about health anyway. But but in thinking about the fact that like how you were thinking about in the future, thinking about mental health as it's tied to physical health, conceptually, these are so tied together because they're biological aspects that are just manifesting in different ways. And so as you kind of think about your future work in this area, thinking more about the kind of complexities within which we see these dynamics. And I love this idea of kind of a latent kind of progression that you're seeing, but these things are tied. They're all part of metabolic and inflammatory issues that we have that are related and then manifest as mental health and manifest as physiological outcomes. And so you might even have more purchase thinking about the two together or thinking about them on this kind of progression that you're proposing.
No, that's a really great point, because I have been thinking about it more like, okay, if we think about sort of longer latency periods, like physical health outcomes, maybe then mental health is sort of like part of that mechanism or pathway. But you're right that it's probably not quite, it's probably a little bit more complicated than that. Yeah.
Thanks for the great talk. I was wondering if you had done a sensitivity analysis before, looking at the data collected from the 3 or so states that saw a change in policy in terms of basically, because I think its effects at the state level can only be so much when it doesn't match the level of analysis. So I think this is individual level data. The 2% change, the difference in the event is at the individual. So I was wondering if you have any thoughts on that.
Yeah, that's a good question. And I sort of brushed over a little bit of the methodological information, but these models are going to be picking up a lot of that change. So my concern actually was that we didn't have a lot of change at the state level. So anyway, so one of the things that I did actually was I looked at just states who ever had state paid sick leave policies during this point. I haven't looked specifically just at the 4 states that added it, because that's more getting picked up in the model. But I did look at those 12 plus 5, 17, 16 states plus DC together, in terms of, you know, what, and the effects, the results look basically identical. So I don't think the modeling strategy here, is, anyway, so I'm not quite as concerned about sort of issues maybe with the modeling strategy.
Yeah, I think it's still like a stronger case, because you're comparing different people at different time frames across different states. So if you just constrain your data to the 4 states that saw a change in policy, then it's a stronger case, I think, that the effect that we're seeing is due to the change.
Yeah, that's a good, are you an economist? That's a very economic, way of saying it, but you know, and that is sort of more the traditional that we sometimes see is sort of like what happens once a policy is implemented. So that'd be a good sensitivity check. I really like that. Thank you.
So we are right at that time, and so I want us all kind of paper to look in for.
So Rachel, how sensitive were your financial hardship measures to the COVID?
Oh,